Okay, so continuing on with the notes. So for air bronchograms, it's alveolar infiltrates, and so all that means is that the alveoli are filled with fluid. Therefore, you can actually see the tracks through the lungs because of the fluid buildup, and so the contrast between the white air or the white fluid-filled alveoli makes it easier to see with the air-filled bronchi. And you can still see the heart, which makes it an air bronchogram. And so I just did a quick illustration of this. And so what happens is you have your air-filled bronchi, right? And so they're surrounded with the fluid-filled alveoli. And so it makes it very clear to see this air bronchogram. And they also describe it as fluffy looking, like a cloud. And you can Google a chest x-ray of air bronchograms to see this. And so the other type is called Reticular Nodular. And so in this case, it's interstitial infiltrates. And in this case, just like the air bronchograms, you can still see the heart. And it's described as if you can pick up the infiltrate with tweezers. So if you can't see the heart, it's considered a pleural effusion, especially if it's the trachea being pushed away from the white, which would be the pleural effusion, and the ribs are bigger on the side of the pleural effusion. Another thing to note is the meniscus sign. So a pleural effusion is just an accumulation of fluid in the pleural cavity. So what happens is, because it's a fluid, you have the characteristic C shape, like what we learned in chemistry, where at the edges you have surface tension causing it to have this characteristic C shape. And so once again, you can Google that to see, for example, in a test tube where you have that meniscus sign. And so it can also is atelectasis, and so this is also where you cannot see the heart. And what happens is the trachea is pulled towards the white space and the ribs will be smaller on the white. So I recommend that you Google a picture of both of these and it'll be very obvious that atelectasis is where the trachea is pulled towards the white and then the ribs will be smaller, and then in pleural effusion it'll be pushed away. And so the next point is, in general, transudative versus exudative. Transudative is caused by increased hydrostatic pressure or decreased oncotic pressure. Now remember, in cirrhosis, liver damage, or nephrosis, kidney damage, there's decreased oncotic pressure, which means that there's less protein in the blood. So if there's less protein, that water in the blood will end up going into the tissue, and so which would cause increased hydrostatic pressure, or it would cause increased flow into the tissue. So to determine if the pleural effusion is transudative versus exudative, use Light's criteria. So in this case, you would do pleural fluid protein divided by serum protein, and so this would have to be greater than 0.5, or you could do pleural fluid LDH divided by serum LDH, and this would be greater than 0.6. And then finally, you do pleural LDH would have to be greater than 2/3 the normal upper limit of serum LDH. Don't mind the culture, that's just a typo. So if one or more of these criteria are met, then it's considered an exudative pleural effusion. If it's not met, then it's a transudative. So once again, transudative is the cirrhosis, nephrosis, or congestive heart failure. So these two would be caused by the decreased oncotic pressure. Congestive heart failure is due to the increased hydrostatic pressure. And so moving on, so exudative, once you've used Light's criteria to determine that it's exudative, right? Exudative can be parapneumonic, and so this is mainly neutrophils. So it can be uncomplicated, less than 10 millimeters on a decubitus chest x-ray, and it usually resolves with treatment. Or it can be complicated, so it's low pH, less than 7.1, low glucose because the bacteria are using up all the glucose, and high LDH because of all the damage happening. And there can be septations, which are fibrous strands, or it can be an empyema, and that means that the pleural fluid is infected and there's pus at the thoracentesis, or there's a positive gram stain or positive pleural fluid. If you have one of these or more, then you can consider it an empyema. So this is very important clinically because you need to drain these and not let them sit, because these patients can quickly collapse. So, and the thing is, if you just give antibiotics, they can't actually penetrate it well. So therefore, you have to drain these, then give antibiotics on top of it. So another thing I'd like to talk about is the monocyte predominant exudative pleural effusion. So there can be a lot of different causes, but the most common are a malignancy, cancer, or tuberculosis. So multiple thoracentesis are recommended because diagnosis through cytology for the malignant effusion increases as you increase the number of thoracentesis procedures done. So for example, there's a 90% success rate for finding any malignancy when you do 3 thoracentesis versus just 60% if you just do 1. And so people with TB usually have a high ADA, right, the enzyme, but they have a negative AFB, acid-fast bacilli, because a theory is that it's hard for the TB to slough off into the pleural fluid, and that's why it tests negative. And I'll continue in the next video. So I hope this helped, and thanks for watching.